I will start today's EKG conference, and I am Asian Korea Secretary Cho. This is the initial EKG. So, what do you think about this EGMA?
No sinus rhythm, irregular rhythm, and pre-excitation. Atrial fibrillation and with pre-excitation.
Why do you think about it? Exactly.
WPW.
Why?
Why?
Because we can see the V5 and V6, it seems like yesterday. Yeah.
Yeah.
So wide cardiac rate is about 180, and rhythm is irregular, and there is a bit variance of cardiac morphology. I think it's AFib with rapid ventricular response, and also right, Agama mentioned with the pre-excitation.
Yeah, but any other mention? No?
I think the heart rate is irregular. Heart rate is around 200, and it is possible to narrow complex tachycardia with ventricular wave or atrial fibrillation. It's possible to narrow.
What about aberrant conduction?
SVT with aberrant conduction.
Yeah.
Usually aberrant conduction makes RBB pattern, but this is not.
Yeah, I perceive. His name is 15-year-old Wu Chan, male, 50-year-old. His complaint was palpitation. The patient went to intermittent episode of palpitation for 3 years. 1 day before visit to emergency department, palpitation, chest discomfort, and dizziness were developed. Initial pressure was 125 188, but compared to 6.3. After his cardioversion, he was terminated, and you can see the augmented tension right away. Chest X-ray, there was no special findings. And in laboratory finding, there was no specific finding by the elevation of the troponin T and protein. So initial transient cardiography was normal. It's the fractional atrial fibrillation. And we did the catheter EPS and catheter evaluation and right. You can find right lateral X-rays and also an ABRT.
Who is hey, hello,
Yes.
Hello.
So,
you guys listening?
yes,
Yes,
Good morning.
good morning.
morning.
Hey, so what is the first EKG you guys read? I did not hear your conclusion or consensus. Tell me what you see here. First of all, this EKG is a consistent with the aberrancy that you talk. I assume you're talking lap on the branch block aberrancy, right?
Yes.
Yes.
So if this is a lap on the branch block aberrancy, typically what you see?
No.
Why is that? Tell me what is not typical here. That's more important now.
First, there's bit-to-bit variation.
Bit-to-bit variation mean QRS is width or duration or what? What is varying?
Purpose and duration is different.
Okay, so there's a unusual form of QRS complex that's changing. That's what you're describing, assuming, right?
Yes.
Now, if you look at the lead 2, 3 AVF, okay? What do you see? Point out which one is a QRS, which one is not. AVF. AVF, quote there, AVF. Yes. One is a deeper S, the other one is a little bit noisy looking fragment signal. That's a QRS complex, right? So what's happening here? Your X is what? Almost changing, bit to bit.
Yeah.
Maybe more than 60 degrees at least, I can see. So there's a second unusual form of a bundle branch, your aberrance we are talking, right? And then what else do you have? This ABF, what do you see? Why every small complex that you see, second complex I'm talking, and a fourth, fifth, and then seventh, keep changing? What did that mean? If you consider that the deep S wave is a regular one, between two small ones, keep getting bigger, bigger, bigger. What is that? And then rate get faster. So you may consider this is some sort of fusion going on, or different degree of aberrancy going on, but you already said there's aberrancy, so it can be. What might be? So let's think about that in a minute now. Do you see any atrial activity in this ECG? Point out to me what the atrial activities are. Look at the precordial, B4, B5, B6. Do you see it? Last bit. Yeah, that guy, yes. Now you march back. Come back slowly. Which one you might think that is another notching, whatever, P wave. Atrial activity, there's another one, okay? So then you think about a little bit, maybe that end of a QRS, that notching thing could be atrial activity. So then this gentleman or whoever patient might be, HR rate is very fast, right? Maybe even faster than your ventricular rhythm. So differential diagnosis would be what? Atrial fibrillation, or some sort of atrial tachycardia, or atrial flutter, atrium happening, and then your ventricle having several different type of QRS morphologies keep changing. So let's think about clinical scenario here. Everybody said that this guy has a pre-excitation. Okay. So number one question, why the QRS change in pre-excitation? You think it's going between sinus and the pre-excitation changing, or there's something else happening?
Some signal going to AV node, but some signal going to accessory pathway fusion.
Okay. That's one possibility.
Mhm.
How about the other? Nobody said this patient has only one pathway, right? Could they have more than one pathway?
Yes.
If that happened, what happened? QRS morphology change during the atrial fibrillation or faster tachycardia, flutter, or either activated tachycardia. So, lesson that you have to learn from this ECG is that if you have a WPW patient, we purposely induced atrial fibrillation long time ago because we had to send the patient to surgery to fix it. So we want to know every single pathway exists in this patient's heart. So we induce atrial fibrillation purposely. Then you will see different QRS complex, different pathway. That means differential diagnosis is what? This patient may have more than one pathway. Okay? So if you have atrial fibrillation, somebody has WPW, chance of going through the AV node far, far less than going through the pathway. So if you have more than one pathway, they rather go to the both pathway. Okay? Because there's no decremental property with actually pathways in general. Therefore, atrial fibrillation sometimes is useful maneuvering during the WPW assessment that you don't know whether the patient has one or two pathway, you're not certain. You induce atrial fibrillation to see how many QRS morphology you get. You get more than one, then you need to suspect at least or work out for second pathway. Okay? That's the message you get from here. Okay, let's go ahead. Go ahead. Yeah, finish up your whatever you study. Okay.
And this is post ablation.
Okay, so where's the pathway? This EKG. Let's go back. Where you suspect this patient has a pathway? Where's the location? Delta wave is negative. Well, go to the AVF or not?
No case.
Okay. So how come you diagnose the right lateral pathway? How do you know it's the right pathway? EKG tell you that, or you just studied it?
Maybe study.
Oh, you studied.
Yeah.
Okay. So when you look at this ECG, what do you think?
It is very short PR.
Short PR. What else? So if it's a short PR, then patient maybe not pre-excited, minimally pre-excited, right?
Yeah.
And based on this ECG, can you make a diagnosis of RPW?
No.
No. Is there any other ECG? Sinus rhythm. This is the only ECG you have?
Yeah, now.
Okay.
Pre-ablation. Yeah. This is the
Yeah.
different after.
Yeah. Then you're gonna look at this EKG now. So you have EKG in the top.
Mhm.
Where's the pathway? You gotta learn these things first before you do ablation, okay? So delta is a positive what? Lead one? Positive delta? Agree?
Yes.
Yes.
AVL?
Positive.
No Q wave. This is positive most likely. How about lead two? Lead two? Lead
Positive.
two positive. How about lead three? Negative, right? Yes. And then AVF biphasing. Okay. And then V1 negative or positive?
Negative.
Negative. So now and then rest of precordium is, it looks like a positive or biphasic, correct? V2, V3 is a positive, V4, V5, V6 is a biphasic. Yeah. So where is the pathway now? You'll just look at the ECG. Where's the pathway, guys? So is the right side,
Right.
agree? Right?
Yes.
Yes.
The most negative lead is what? 3, right? Delta most negative is lead 3, am I right or no?
Yes.
Yeah, that's where the pathway is, okay? So whenever you have a maximum pre-excitation negative, usually point to where the rough location of pathway. That means right side free wall pathway. Okay? Any question about this or no? Okay, then let's go then. So you know how to look at the ECG now. Go ahead, please.
Oh, this is the last.
Anybody has any other comment or no? Okay, let's move ahead.
This is the final slide. This is the final slide of.
Final EKG. So you have the post-ablation ECG, you mean? Is that the post-ablation?
Yeah, this is.
Okay. So you ablate now go back there, your EP study, you said something about that. Show me the EP study. Why you said is for the manifest right, okay. And the orthotomic AVRT, okay. So you basically only able to induce the retrograde conduction pathway. No antegrade conduction. Tachycardia, right? Just
Yeah.
orthotomic tachycardia. Okay. Now you have 3 catheters there. Where is the you don't show me aerial view anyway, but where is the 3 catheters is located? Duodeca to the right tricuspid annulus or decapolar. And then you got the ablation there with SO1 sheet. What is that small other catheter located? The quadripolar, yeah. Do you know where they put that in? I assume you guys put the right spot, but I'm just curious where they put it in. So if you know that the patient has a right lateral wall pathway, you are looking for ventricular insertion site or whatever you might be, then you want to put a catheter right ventricle free wall area where it's a close to pathway. So you can induce tachycardia and map faster and easier, okay? All right. But one thing that I'm worried about still that you folks have not put a His bundle catheter yet. Especially somebody, you might have more than one pathway. There might be a mistake. So if you're doing SVT ablation, I don't care whether WW, AVNRT or might be, you don't want to miss His bundle. Okay? I mean, that is not complete study. So you want to make sure that you study after the ablation, there's no other auxiliary pathway around. Make sure that you do complete testing. Okay, this is a 15-year-old kid. I just read it a little bit. Okay. Any question, anything that you want to ask?
Actually, I did not fully understood in this ECG where is the point of.
Okay,
X-ray.
so
Yeah.
impulse coming from the atrium, going to the axillary pathway where the ventricular insertion is, correct?
Yeah.
Then impulse gonna move away from there to the rest of the heart.
Yeah.
Then that area should be what? Negative. And most pulse is gonna be opposite direction, right? Yeah, no, did you understand this, what I'm telling you or no?
Yes.
So in other words, same as the PVC. If you have the PVC from the right free wall, you're gonna be what? Negative Q wave that area, right?
Mhm.
So you're only looking at the delta wave. You're not looking at the QRS. So look at the delta wave force 40 milliseconds. That's what you did. That's why you said the lead 1 is positive, lead 2 is positive, lead AVL is still positive, and then V1 is a negative, V2, V3 positive, and the rest is biphasic, V4, V5, V6. Okay? And the only most negative delta wave is the lead 3. Therefore, delta wave is right there. Delta wave is located right there. So atrial activation going through that lead 3 area to the ventricle, then rest of QRS become that shape. Understood? So wherever source of a focus arrhythmia, always going to be most early and negative vector. Activation going to move away from there. Okay? That's a concept. Any other question?
Good morning, Dr. Huang.
Good morning. How are you, Han? Are you doing
I'm
well
good,
in
thank you so
Cambodia?
much. Yeah, I'm in Cambodia right now.
Okay.
I have one question to ask you also. For the
Yeah.
ECG post-ablation, what do you think? Because we also see still patient has the short PO, but even after the data wave is gone, it's still short.
Okay. So
So
what is your concern? Short
because
PR?
yeah, short PO.
Why?
So
Is that this is a 15 years old, what I understand, right?
yeah,
Okay. And then if you look at his ECG, what do you see? After the ablation, he still have a significant rightward forces in the ventricle. 2-3 AVF are very tall. Okay.
yeah,
And then transition of R wave is not that great, this kid. B1 still have a pretty tall R wave. So what does that mean? Depending on the heart rotation and size and maturation, age, children tend to have a much more rightward axis normally because you're born with the pulmonary hypertension during the fetal circulation. That gradually evolve change, and then also depending on how fast your development it is, your rightward axis resolve gradually become more leftward. This kid in transition looks like. Now, many children, they don't have what we call fully compacted AV node, what we call dispersion AV nodal tissue. If you look at the pathology data from Anderson's group, England, they describe this very well. Matter of fact, in the children, neonates, pathology specimens show, many of them shows nodal ventricular conduction directly because the AV node is pretty much scattered among the fibroid tissue. So during the process of maturation, I think that tissue become consolidated, become compact AV node. Depending on the how much dispersion you have, you can have a very short PR because of your decremental conduction property. Nodal tissue is not that greatly formed yet. So PR interval can vary widely. This patient probably, lower limit of PR, normal PR. I think 1, 2, 3, 4, probably about 120 millisecond maybe. So it's not a quite bit of a junctional rhythm, 110, but I think it's still normal sinus rhythm, I would say, because the PO axis is appropriate. So PR, short PR doesn't bother me. Only thing is that whether a patient have a second pathway present, that has to be concealed or something. But then delta wave is definitely gone. Did I answer your
okay.
question?
Yeah, thank you
So
so
if
much.
if you're curious about this, you can read the paper by the Anderson and the Bob Anderson. Robert Anderson is a pathologist, cardiac pathologist in England, London. He is written many articles on this. Look at the embryologic and neonatal heart development paper. You may learn a lot of new things there. It's very interesting.
Okay.
Yeah.
Thank you.
You're welcome. Any other thing? We got 3 minutes to before start the international conference. So it looks like a lot of senior members missing there today. Okay. Nobody, if you guys don't have any question, we're gonna go ahead to move it to the international conference. Let's get ready to go. Okay?
Yes.
All right. I'll see you next week. Take care.
Thank you.
You're welcome, sir.
Okay, today we are gonna start monthly international evening case conference and it's already